Guys, and we're going to get started in just a few minutes. Looking forward to talking with you soon. Hey guys, we're just going to get a few minutes for everybody to get on and get joined, and then we'll get started. Hey, you guys, Dr. Haverland here. I'm just going to give a few minutes for a few stragglers to join, and then we will get started shortly. All right. Hello. We're going to get started shortly. We have a few more people that are joining in. So I'm just going to give another moment or two to get them all joined, and then we will get started. Okay, guys. I think we're going to get started. I am Dr. Rachel Haverland, as you know, with Endometriosis Center of Excellence. And as we go through this webinar, it'll be here for about the next hour. I'll be talking with you guys about endometriosis, how it can be frequently misdiagnosed and missed by other providers without kind of connecting the dots. I think it's very important to understand the process of endometriosis, how it is a whole body disease, not how it is just one, entity or etiologies that's contributing to your symptoms. And so, anyways, I hope that throughout this hour you learn a little bit more about endometriosis, and hopefully you'll be able to advocate better for yourself, for your loved ones, um, and just learn more about this disease is actually very common. I do this about once a month, trying to advocate for the disease and also to educate my patients, educate their partners about it, educate family, and hopefully one day just educating more physicians as well about how prevalent the disease is and how debilitating it is. So anyways, I am glad that you joined me today. Like I said, we'll be here for about the next hour, talking about, endometriosis. There is a chat on the side. Please use that chat so that this can be interactive. I would love to get to know you better, talk to you, answer some questions as we're going through. I won't be able to get to all of the questions, but I would look for some of them and be able to interact and answer some questions as we go along. Also, one thing to note is that in the chat there is a link to set up a visit with me. So this link that you'll click on actually is a scheduled visit with my office manager. Her name is Cyrus. And at this visit or at this time scheduled on the calendar, you'll be able to talk to her about scheduling a visit with me. So that calendar link that you have is not a visit with me directly. It is a visit with Cyrus. At that point, you'll give her your insurance information, talk to her about scheduling it, and then she can help get you on the schedule. You do get some preferred times and appointment dates for that. So I think I have let in most people that are coming to join. So let's go ahead and get started. So, what this webinar is talking about, is your pain just stress or something, that no one checked for? Women in Texas, let me ask you something honest. If one more doctor told you your pain was just stress, would you lose it? You've been told it's anxiety, IBS, UTIs, hormones, burnout. You're doing too much, but you're still exhausted. You're still bloated. You're still hurting. Still waking up feeling like something's wrong with your body. You're not crazy, and you're not broken. There is a very real possibility that no one ever checked for the right things. And here's what happens to thousands of women every single year. You go to the doctor with pelvic pain, gut issues, fatigue, pressure. They run the basic tests. They don't find anything obvious. So they label it. You get labeled as having stress, anxiety. Many of my patients get diagnosed with IBS or recurrent UTIs or even interstitial cystitis. And once that label is on you, everything you say after that kind of gets filtered through. They're like, oh, okay, well, it's probably related to your prior diagnosis. That's not medicine. That's dismissal, especially if once they give you a diagnosis, you're not seeing improvement. You're not getting better. And the longer this goes on, the more you start doubting yourself. You wonder if you're overreacting, if you should just push through it, if this is your new normal. It's not, and it shouldn't be. I'm Dr. Rachel Haverland. I'm a board certified gynecologic surgeon and endometriosis specialist. All I do is endometriosis. I don't deliver babies. I don't do, hormone checks. I don't even do pap smears. This is the only thing that I focus on. I work with women every week who were told for years that their symptoms were physiological, that they were digestive or just, part of being a woman until we looked deeper. This is not about blaming your doctor. It is about understanding why the system misses patterns and how to stop being the one who pays for it. And this is very, very important to understand your symptoms, but also to advocate for more. Ask better questions. Ask for more understanding. Ask for answers. And I think that many women get mislabeled. And so we're going to go through, a few kind of secrets of how to navigate this, and then ultimately talk about how to advocate for yourself and find more answers. So why do so many women get mislabeled? So that's the first question. So Young women especially are less likely to be listened to, women in general. But here's the uncomfortable truth. The medical system is great at treating isolated symptoms. It's terrible, however, at recognizing patterns. The doctors don't talk to each other. Even though you have bowel symptoms and bladder symptoms and painful periods, these doctors are not communicating with each other. It's just not set up that way. Fatigue gets sent to primary care. Gut issues go to gastroenterology or GI. Pelvic pain gets brushed off as just normal, period cramps. But when these symptoms show up together, they often point to something deeper. I've had many patients with similar stories to this. They come in, they have been diagnosed with IBS, anxiety, interstitial cystitis, kind of the triad, right? So you have bladder symptoms, bowel symptoms, and nobody really has talked to them about how they may all be related to the same etiology. They may not be individual diagnosis, and they can be. Certainly, you can have endometriosis and also diagnosed with these other symptoms, but it's frequent that endometriosis is what's causing these other symptoms that you're experiencing. It's not just IBS. It's usually endometriosis affecting the bowels. So I've had many patients, but frequently I saw a woman, you know, I think this was 2 weeks ago now, and she was talking to me about the symptoms she's experienced. And I always ask, how are your bowels? Do you have pain with bowel movements? Do you have constipation? Do you have diarrhea? Does it alternate? We ask about bladder symptoms. Do you feel like you have a UTI, but frequently go to the doctor and you have negative, bacteria on your culture? Do you ever have pain with intercourse? How is your fatigue? What about food sensitivities? All of these things are related to endometriosis. How about other autoimmune diseases? Endometriosis is frequently diagnosed with other autoimmune diseases. Fatigue is one of the most common symptoms of endometriosis. Commonly, you have constipation. You can have pain with bowel movements. Can have diarrhea as well, alternating constipation and diarrhea. Endometriosis does not necessarily discriminate. It can affect all of the organ systems. And so this patient came into me and she was talking to me about her bowel symptoms. She has alternating constipation and diarrhea. She has pain when her bladder is full, feels like she has interstitial cystitis. She's been diagnosed with both anxiety, interstitial cystitis, and IBS. And as we started talking to her and kind of really getting down to the underlying cause, asking her, well, do these symptoms fluctuate throughout the month? Do you notice that they are present every day? Is there some times when they're getting worse, or there's sometimes they're getting better? And no one ever really connected the dots. No one ever asked her how her cycle affected her other symptoms. And that's very common with endometriosis. Initially, classically, women with endometriosis start to have pain during their cycle. As endometriosis progresses, you start to have pain outside of your cycle, rather the week before your cycle or around ovulation, or it starts to affect other organ systems. You start to have bowel symptoms. You start to have bladder symptoms. You start to have pain with intercourse, and it can affect your fertility down the road. But typically, that's kind of the classic progression of endometriosis, and it's important to understand that when you're talking to patients, but also to ask them. Sometimes they haven't even, put it together. I have many patients who have joint pain. They're like, I have pains in my joints. My shoulders hurt, my knees hurt, my hips hurt. And no, it's probably not endometriosis specifically in your joints, but it's related to this whole inflammatory response that your body, is experiencing. And so it's really important to be able to connect the dots and understand that this disease is multifactorial. It is not just a disease of the pelvis, and it is not just a disease of the GYN system. It is a disease that affects us as a whole. And so understanding the etiology of endometriosis, how this inflammation causes pain, but also how this inflammation affects other organ systems is paramount, and understanding how to treat it with a multidisciplinary approach, and really getting to the root cause so that you have your best outcome. This patient, she wasn't stressed. She did not have stress, was not her diagnosis. She was mismanaged. And I think it's because, the dots weren't connected. they didn't communicate. Without understanding, the whole picture of endometriosis, it's virtually impossible to understand how to treat it. And so this patient, once we went through all of her systems and understood how endometriosis was affecting the organ systems, we were able to put a plan together to really find the root cause. And so endometriosis is treated with a multidisciplinary approach, which includes diet, exercise, acupuncture, pelvic floor physical therapy. Sometimes hormones can help, especially help prevent endometrioma recurrence or treatment of adenomyosis, which is a common kind of similar a common disease that is very common with endometriosis. At least 30% of women with endometriosis have adenomyosis. But ultimately, the gold standard of treating endometriosis is excision surgery, and to clean out the uterus. For polyps to evaluate if there is adenomyosis, and then to clean out the pelvis for endometriosis implants. One, be able to identify them, and two, be able to excise them. So that is the gold standard for treatment, because none of the medications we have make the endometriosis go away. It may help suppress some of the symptoms. There certainly can be side effects from these medications. They're not wrong, but they're not for everyone. So the gold standard of endometriosis treatment is surgical excision. And so that's kind of where we start with our treatment plan, is making sure we're getting to the root cause. We're removing the underlying cells that are causing this inflammation. And excising the endometriosis. Again, this is all I do. I just focus on endometriosis. I did a fellowship, at Mayo, which very much was heavy in endometriosis. And what we do is we evaluate everything. If we're going to go to surgery, I want to do it once, and I want to do it right. I look at the diaphragm, the liver, the gallbladder, the spleen, the stomach, the small intestines. I look at the appendix. We look at the colon. I feel very comfortable removing endometriosis from the colon, from the bladder, from the ureters. That's the tube that carries urine from the kidney to the bladder, around the ovaries, preserving the functionality of these organs. Most of the time, 99% of the time, we keep the ovaries. The ovaries have a lot of benefit for us. So even if there is a large endometrioma, your risk of recurrence may be a little bit higher, but most of the time we can still preserve that ovary. We want to preserve the natural organs as much as we can. So removing the cysts, preserving the normal ovarian tissue, but excising all of the disease with wide margins. I do have doctors in almost every specialty that I can call on if needed. I have colorectal surgeons, I have urologists, I have general surgeons, we have vascular surgeons, we have cardiothoracic surgeons, for more invasive lung disease. But ultimately, the goal is we want to be prepared for whatever we find going in, make sure we remove all the disease that we can see, and also make sure we do it safely, but thoroughly. Again, do it once and do it right. So endometriosis excision surgery is very much the gold standard and kind of the baseline of removing endometriosis. And so at that point, once the endometriosis cells have been excised and removed, then you can start to see more benefit from some of these other modalities going forward. And so, the first thing was, why do so many women get mislabeled? The next kind of topic is, why do tests come back normal? So why do women get mislabeled, and then why do all the tests come back normal? So another thing that women hear all the time is, your scans look normal. Normal does not mean nothing's wrong. It means the test was not designed to look to what's actually happening. Let me clarify that again. Normal does not mean nothing is wrong. And I think this is very, very important to know and to advocate for yourself. Just because your ultrasound or your MRI shows normal, it does not mean that there's not something wrong. It just means that they can't see it. Endometriosis frequently is not seen on imaging, especially early stage disease. Once you start to have an endometrioma or a large cyst on your ovary, we are able to identify that. Or if you have deep infiltrating endometriosis in your colon with stage 4 disease. But we don't want to wait to catch it until it's stage 4 disease. The goal is to catch endometriosis early. The earlier, the better. The better chance that we can reverse some of the nerve damage, some of the sequela that endometriosis has caused, better chance that we can preserve your fertility, better chance that it doesn't damage the ovaries for longevity. But it is imperative to understand that imaging is not perfect, and nothing that we do is perfect, but imaging frequently misses endometriosis. And so, a lot of my patients, I will make sure that they have some sort of imaging, but if your imaging looks normal, that does not rule out endometriosis. In fact, it really doesn't help us at all. We know that it's there. Maybe it rules out deep infiltrating disease onto the colon, but it doesn't always. I've had MRIs and ultrasounds frequently, miss these signs that you can see on imaging. I always look at my own scans to try to help avoid misses, but it's, again, frequently, even when I go back and look, it really doesn't look abnormal, but when I go in for surgery, you can obviously see the disease. So normal imaging does not mean there's nothing wrong. So many pelvic conditions don't show up on standard imaging. They don't announce themselves clearly. They hide in plain sight. So when doctors don't see an obvious problem, sometimes they assume the problem is you. Is this psychosomatic? Is this anxiety? Is this stress? But that's backwards. That's not how it should be. I joke sometimes that my job is actually very easy. I just talk to women, listen to them, and then I believe them. And then we make a plan together as to what next steps are. What are the best next steps as far as management plan? Have we reviewed all the different organ systems, like your GI system, your urinary tract? Have we talked about fatigue? Have we talked about your desires for reproduction? Have we talked about pain with intercourse and sort of what your daily functioning is, what are your goals? But it is imperative to understand that many women in this, that live with endometriosis have been told that nothing is wrong, that their scans are normal, and if they have normal scans, that there can't be any disease. And that is absolutely incorrect. I see that daily. I probably see it, 10 times a week, women that have normal imaging, but when we go to surgery, they have endometriosis. So normal imaging does not rule out endometriosis in any way. So I will get off my soapbox for a second and go over to some of the chat again. Thank you for using the chat so that way this can be a little interactive. One thing that I wanted to mention, and I see some of you guys have been scheduling, is that there is a link in the chat. This link is a scheduled time on the calendar to meet with my office manager. Her name is Cyrus. At this visit, she will talk to you about scheduling a visit with me directly. But remember, this calendar invite that you're signing up for is to meet with Cyrus, my office manager. And at that visit, she will go over your insurance, she'll go over, times that she can get you scheduled. And then at that point, you will get on the books with me. So just so you know, this calendar invite that you're doing right now is not a direct visit with me. It is with Cyrus, my office manager, who will help get you scheduled to see me. And she does have some scheduling options there that are not available for everyone that just calls in. But I'm going to, again, go through some of the questions. Let's see. This is a good one. Can you explain the link between IBS and endo? You had surgery, but I'm still having IBS symptoms. So endometriosis, like we mentioned, is a whole body inflammatory disease. So there's a few reasons why IBS can be affected. One is women with endometriosis tend to have more food sensitivities. A recent study showed up to 70% of women with endometriosis had gluten intolerance. Does not mean you have celiac disease, but a woman with endometriosis and a chronic inflammatory condition does not process foods the same way as somebody without an inflammatory condition. And so you're more likely to have more food sensitivity. So that certainly could be one. Trying to decipher and find foods that cause you to flare, that cause you to bloat, that can bring on that diarrhea or the constipation or the alternation. And so the first thing to really look into and to do a deep dive is food sensitivities. I use some dietitians that my patients can meet with to talk through the different options for for diet changes and kind of working through finding foods that are more inflammatory for them. I like starting with whole foods diet. Whole foods is lean meats, fruits and veggies, and then adding or subtracting foods as you feel like you can, to try to find a diet regimen that's less inflammatory for yourself. But so that's the first part with IBS. Next is endometriosis causes chronic inflammation. This inflammation is typically in the pelvis. 99% of the time, there's at least some pelvic disease. And with this chronic inflammation, it slows the peristalsis of the colon. And so the inflammation kind of slows the nerves that are causing the muscles to push the food through the colon, and the small intestine. And so it's very common with endometriosis to have more constipation or this alternating constipation diarrhea because the nerves are not functioning as well as they should be because they're being affected by the endometriosis. Now, and I do talk to my patients about this and kind of set expectations. Many women after endometriosis surgery see a benefit in the pain with bowel movements. In fact, you should. If all endometriosis has been removed, you've done physical therapy, physiatry, whatever next steps are, you should see an improvement in your pain with bowel movements. However, sometimes people continue to have chronic constipation or alternating, diarrhea and constipation. And this is more related to the damage that the endometriosis has done to the nerves on the colon. So even if all endometriosis has been excised and removed, some patients still continue to have symptoms, and that's more related to the residual damage that the endometriosis has caused. Some patients have had endometriosis for 10 years. Some people have had endometriosis for 20 years or 30 years. And so that chronic inflammation does cause damage, and sometimes it's long lasting. For my patients with constipation, I like natural magnesium citrate. Most of us are low in magnesium anyways because we don't eat bananas, but it is a more natural way to help supplement the bowels. It's usually not caustic like some of the other laxatives, and it's more of a natural approach. And usually it works very well. You can titrate it. So some people need 200 or 400. Some people need, 1,500, but trying to find like a dosing that works well for you, they can help you have a soft daily bowel movement. But that's why even after endometriosis is excised, if it was truly excised, you need to make sure that all endometriosis was removed, all visible disease was removed. But if all visible disease was removed, your pain should improve, but the alternating constipation or diarrhea, or sometimes the constipation symptoms continue, and that's because of the nerve damage, unfortunately. But also make sure that you've worked with a dietitian to really look into the food groups, because our bodies with endometriosis do not tolerate the inflammation as well as somebody without an inflammatory disease. Let's see. This patient said, or this person said on the chat, I had a doctor tell me in 2007, oh, you had a little bit of endometriosis, but we're just not going to worry about it. And I think that's very devalidating. Endometriosis is very real. It affects 1 in 10 women. It's the most common cause of unexplained infertility. At least 30% of women, going through the fertility journey have endometriosis. It's again a very common cause of pain. Any amount of endometriosis can be debilitating. And that's one of the tricky parts about endometriosis is the stage does not always correlate to symptoms. So you can have stage 1 endometriosis and be debilitated, like unable to function, unable to go to school, unable to go to work. And then I have other patients with stage 4 disease. They have large endometriomas. Their bodies are riddled with endometriosis, and they're relatively asymptomatic. And so it does make it, you have to really listen to your patients and understand. Now, my asymptomatic patients with advanced disease, most of the time when I talk to them, I can kind of tease out some other symptoms of endometriosis if you really know what you're looking for. But endometriosis is not a one size fits all. It does not follow the rules. But endometriosis in any regard should not be devalued. Stage 1 endometriosis is just as debilitating as stage 4 disease. I think it's very important, one, to make sure that you treat endometriosis correctly. So we're talking about endometriosis excision surgery. Sometimes stage 1 disease is difficult to remove because it's more subtle. So you have to make sure you're getting really wide margins around this disease. One, make sure that you can identify it. So young women, 25 and under, sometimes their endometriosis is a little bit more atypical, meaning it's less obvious to the naked eye. It can look like scar tissue. It can look like little clear blisters, and it can look like brown staining. The classic look is kind of like a black powder burn, like a cigarette burn, but frequently it doesn't look that way. So one, it is imperative to be able to identify it. So that's the first step. Know what endometriosis looks like. Next, once you're able to identify the endometriosis, you need to be able to remove it. Remove it from the nerves, remove it from the rectum and the bowel, remove it from the bladder, remove it from the ureters, be able to remove it safely. And also, next, to get wide margins. So wide margins, especially around early disease, are imperative so that hopefully we're catching some of that microscopic cells that are near the other areas that are visible. And so it's really important to have a specialist in endometriosis that understands, because a small amount of endometriosis should not be dismissed. That endometriosis can continue to grow if it was not excised. It can still affect your fertility at a low stage. There are stressors in life, infections, life stress that can sort of exacerbate the endometriosis to grow faster, or it may not even be stress. It might just be bad luck that the endo starts to aggressively grow. And so it is very important to understand the etiology of endometriosis, how it affects our body as a whole, how it affects the ovaries. So women with endometriosis may not have the same, ovarian reserve as a woman without endometriosis. So their fertility may be affected. Even with low stage endometriosis, it's still at this inflammatory environment. And when you have an inflammatory environment, the ovaries are just not as functional as they would be otherwise. And this is not just for fertility, but for longevity. The estrogen is very important for our bodies. It protects our bones and it protects our heart. There's some cognitive protection with estrogen from our ovaries. And so endometriosis, even at an early stage, can negatively affect long-term outcomes with ovarian function. And so it is imperative to listen to women, but understand the disease, and certainly not to brush them off, because the patient is not the problem. This is not stress. This is not just anxiety. This is not just IBS and interstitial cystitis. This is a disease that affects multi-organ systems, that can affect how your body responds to infection. It can affect your immune system, again, associated with other autoimmune diseases. And it is imperative that not only we understand the disease, but also we understand some of the treatment options. It's not just birth control, and it's not just surgery either. There is a multidisciplinary approach so that you can get your best outcome. And so I'm going to keep going again. So the first thing was, why do so many women get mislabeled? And we talked about that. The next is, why do my tests come back normal? And we talked about that standard imaging is not perfect and frequently it misses the disease. And the next is, know the questions that change everything. Understand the right questions to ask. What finally gets women answers is not another medication. It's asking the right questions. And that's what I want to try to teach today, is understanding, advocating for yourself, but then also trying to ask the right questions to get answers and hopefully help in your journey with endometriosis. So questions like, hey, why do these symptoms flare together? Why does my IBS tend to cause more pain? Why does my interstitial cystitis and my bladder pain or frequent UTIs flare around my cycle or right before my cycle? Why is my inflammation and my bloating, getting worse between ovulation and my luteal phase before I'm getting closer to my cycle? Or why did I used to just have pain with my cycle and now I'm having pain every day? So why do these symptoms flare together? That's a very good question to ask. And hopefully you're starting to get the understanding that they are very much connecting the dots to understand that endometriosis is a multifactorial, the way that it affects the different organ systems is quite significant. It is not just a pelvic disease. So, next question, why do they get worse around my cycle? So, why do they flare together? Why do they all seem to get worse together? And then why do they flare around my cycle? And this is starting to make you think about the hormone fluctuations. So, when you get to a woman's cycle, your hormones fluctuate throughout the month. If you're not on any type of hormones, you have hormone surges before you get to ovulation. And then right before your cycle, some of these hormones sort of crash down when your body realizes that you're not pregnant. And so there's huge hormone swings that are affecting this inflammation. And it's not just the estrogen and progesterone that is affected. It's also your cortisol. It can affect many other hormones in your body that can be related to inflammation. So the next question that you should ask is, why do treatments help temporarily but never fully fix it? So when you're at the GI doctor and you're getting treated for IBS and you start with different management, whether you work for diet or you try different medications to help with constipation, for example. So why do they help short term, but then after a while they stop working, or it gets a little bit better, but it doesn't resolve. So what are we missing? Why do they help for short-term relief, but not long-term relief? Same thing with the bladder. Why after, changing diets, doing an IC diet, decreasing the acidity and alcohol and coffee, why am I still having these same symptoms? Why did it get a little bit better, but it hasn't resolved, or these medications to help with like bladder spasms? Why is this improving, but why only for a short time, and then it kind of stopped? And that's why it's important to connect the dots at this point. When you ask better questions, you get better answers. And unfortunately, the onus should not be on the patient to do this. But sometimes you have to. Sometimes you have to advocate, for yourself to be able to get the answers and get the treatment that you deserve. And I've seen this. So even yesterday. So yesterday I had a patient come to me just completely defeated. We talked through all of her history and her symptoms. Once we reframed her symptoms as a pattern, so not separate issues, everything changed. This patient was not dramatic. She was being listened to. We finally understood that endometriosis was likely the underlying etiology that was also continuing to cause these other symptoms. Endometriosis affects the whole body, but most commonly it affects the GI system. It can affect the immune system. It affects the urinary tract system with the bladder, and it can affect the ureters. It can even affect the kidneys. It affects your overall inflammation. Women with endometriosis tend to have elevated inflammatory markers, also common with other autoimmune diseases. So it is imperative to understand how endometriosis affects the body. Again, this patient was not being dramatic. And once we connected the dots and we sort of understood how all these organ systems can be affected by endometriosis, we came to the conclusion that this likely is endometriosis until proven otherwise. Some of her other treatment options, sort of like we talked about before, had helped for a little bit and then kind of stopped. Like when she was being treated for IBS, she saw a little improvement and then it tailed off. Same thing with the bladder when she saw a urologist. And so you can see multiple different providers to give you these specific treatments, but frequently they're all related to one underlying disease. So you can see a GI doctor and a colorectal surgeon. You can see a urologist. You can see an immunologist. When you go to these specific doctors, they're going to look at the labs and this specific etiology, but sometimes it's hard to connect the dots if they haven't seen a lot of endometriosis or if that's not something they do frequently. But endometriosis is not an uncommon disease. It affects 1 in 10 women. It is actually very common, and I think it's important for us to learn more about it. In our society, women's health is undervalued, and it is incredibly important. And we should talk about endometriosis. We should advocate for more research about endometriosis, not just educating patients, but also other physicians about endometriosis and how it's affected us as a whole, and hopefully getting more options for treatment plans going forward for a larger group of people. The third thing is the better questions, to get answers. So the questions that change everything, understanding what questions to ask, trying to sort of understand how your symptoms for these different um, um, organ systems can be related. I had another person on the chat said, I was told I had IBS and anxiety. A few more questions in the chat I'm going to pop over to. This patient, she said, I have bilateral endometriomas on my ovaries and bleeding after a hysterectomy. Will surgery stop the pain and bleeding? I am so sorry that you're experiencing this. Hysterectomy does not treat endometriosis. It can treat what they call adenomyosis, which is inflammation of the uterus. Again, very common with both endometriosis to have also adenomyosis, which is an inflammatory issue as well. It can cause heavy bleeding, bloating, pain that radiates to your back and down your legs. It's certainly not a benign condition, but adenomyosis is treated with a hysterectomy, but not endometriosis. We have to make sure with endometriosis that we do a full excision. And at that time of surgery, making sure we remove endometriosis cysts from the ovaries, remove endometriosis from the nerves, from the pelvic sidewall, from the ureters, from around the rectum, from around the bladder. The hardest part about surgery is doing the endometriosis excision, removing all of the disease. If you're still having bleeding after a hysterectomy, you rather have endometriosis at the vaginal cuff, or there's some granulation tissue at the vaginal cuff that's not healing unless you left your cervix. If you leave your cervix, you have a higher risk of having irregular bleeding. So it may be related to endometriosis cells, but it's important to, one, get that evaluated. Unfortunately, when you have recurrent endometriomas, the only treatment option really is surgery. You can take medication for a short period of time, but it's not going to make the endometriomas go away. So surgery is going to be your best chance to really evaluate the ovaries, remove the cysts, because endometriomas do not resolve with medication, and then give your body a fresh start and a clean slate. But unfortunately, when you've had a hysterectomy and endometriosis is still present, we need to make sure that we're a little bit more aggressive in removing the disease so that you have a better chance of it not recurring. Okay, this person asked, wanting to know more about overlap of endometriosis and adenomyosis. So adenomyosis, again, is present in about 30% of women with endometriosis. So adenomyosis is a uterine disease. Endometriosis is not a uterine disease. The definition of endometriosis is that these cells are outside of the uterus. They implant outside of the uterus, and grow once you start getting close to maturity, making estrogen, having cycles. And they are outside of the uterus. They are on your ovaries, your tubes, your nerves, your ligaments. They're very similar to the cells that are in the lining of the uterus that grow and shed with your period, but they're not the same. But essentially, endometriosis is outside of the uterus. Adenomyosis is inflammation of the uterus itself. It is when the lining of the uterus kind of grows into the muscle wall and the uterus gets very heavy, very boggy. The uterus should be hard like the back of your hand. The uterus with adenomyosis is very soft, almost sponge-like. When you look at it, the coloration is not perfectly smooth. Some areas are a little bit lighter, some areas are a little bit darker. It's mottled. We call it mottled in appearance. And adenomyosis specifically causes heavy bleeding. So women with adenomyosis have heavy bleeding. The heavy bleeding is not associated with endometriosis. That's actually typically adenomyosis. Now, it can be with estrogen dominance, but believe it or not, there's many women with endometriosis that do not have heavy bleeding. That tends to be just more localized endometriosis rather than adenomyosis itself. But if you have debilitating pain and also heavy bleeding, there's a high suspicion that you may have both. Adenomyosis is treated with a hysterectomy or progesterone. So endometriosis does not necessarily respond well to hormones. However, adenomyosis does respond well to hormones. Rather, a progesterone IUD or oral progesterone are usually my recommendations for adenomyosis, unless trying for pregnancy. Um, and once the endometriosis has been excised with the gold standard of endometriosis excision surgery, frequently the adenomyosis responds much better, and you start to see more benefit from medications that maybe didn't even work before. But adenomyosis is kind of tricky because sometimes doctors don't know to look for it or even understand much about it, but it's very common with endometriosis. Now, what's interesting is there's also a caveat. If you have adenomyosis that's diagnosed, your risk of having endometriosis is very, very high. It's like 75%. Because if you can see adenomyosis on imaging, or if you can see the adenomyosis at time of surgery, that means it's pretty advanced. And so there's a much higher correlation on the flip side. If you find adenomyosis first, your risk of endometriosis is much higher. So again, I'm going to keep talking, but I also want you guys to look here in the chat. So there is a link in the chat to get on my calendar. And so I just want to clarify, this link in the chat is to schedule a meeting with my office manager. Her name is Cyrus. So this meeting is not with me directly. It is with my office manager, Cyrus. And so Cyrus at that visit is a scheduled appointment where you can talk with her. She'll go over your insurance information. She will kind of go over the scheduling process, what it looks like to schedule a visit with me. And at that point, she will get you on my calendar. She does have a few spots that are saved for webinar patients. But again, this calendar invite that you're seeing in the chat is not a direct visit with me. It is a visit. It is a time scheduled to meet with my office manager, Cyrus, where she will go over the scheduling process and then get you on the books with me. But it is a great way to have some better options for visits. I will warn you, right now we're starting to book out into March and April. But we do have visits pop up all the time. I have cancellations. I have patients that are not able to make their appointments. And so we do have, cancellations that pop up. And so we'll do our best to get you scheduled. I feel very strongly that women deserve high quality care. We deserve evidence-based, high quality care. And endometriosis is it's been dismissed for many years. It's very undervalued, and how many women it affects. And endo is complex. It is not a one size fits all. It does not follow the rules. And so it is very important to sit down and really dissect through your symptoms, understand the correlations that they may have together, understand the treatment options, understand the next steps, but also to understand that your life doesn't have to continue to be this way. This is not how you have to live your future. Your future can be improved. We just need to find a plan that's best for you personally. There's not an algorithm for endometriosis. There's not a try this, try that, next steps. It is very personalized because people, my patients have different goals, in their lives, whether it's pregnancy or getting through the workday, or being able to have, pain-free intimacy with their partner. But really listening and understanding what each person's goals are, and then, forming a plan together. And so I'm going to go back to the webinar and kind of review a little bit. So the first topic was, why do so many women get mislabeled? And that's because we're missing the patterns. Doctors are missing the patterns and not putting it together. Why do tests come back normal? That's also because imaging is not perfect. Frequently, doesn't show up on standard imaging. But just because you have normal imaging, it does not mean that there's nothing wrong. And the third topic we went over is the questions that change everything, giving you some tools to ask the right questions to hopefully get the answers that you deserve. When you ask better questions, you get better answers. So if you've been told that your pain is stress or anxiety or just how your body is, I want you to hear this clearly. That explanation is often a placeholder. It is not a diagnosis. And the longer you accept it, the longer the real issues stay untreated. But knowing that isn't enough. You still need a path forward. And that's why me and my team, we offer private consultations. At your new patient visit, we review your symptom history. We identify, what may have been missed or maybe glossed over or been contributed to other diagnoses like IBS or interstitial cystitis or fatigue or anxiety. And help you understand what to explore next, clearly and confidently. I want you to have time. So this is not a rushed appointment. It's a focused conversation designed to give you some clarity. So there's no pressure, there's no dismissals, there's just answers. In my visit, I give you kind of options. I offer a multidisciplinary approach. If surgery is not indicated for you right away, that is okay. It is the gold standard of treating endometriosis, but it is a big decision. If I think you have adenomyosis, we talk about hormone options. It does not mean you have to do it. I feel very strongly in women's autonomy and you making decisions for your body. But I want you to know all of your options so you can decide what's best for you. Many of my patients are very um, uh, they're very understanding of their body and their symptoms. They are at one with what's going on, and so if you feel that one treatment plan is better for you than other, trust your instincts. You've been fighting this disease for 10, 20, sometimes 30 years. And when you've done a lot of trial and error and you know what works for your body, again, and trust that. Trust yourself to know what's best for you. And again, this multidisciplinary approach typically does involve surgery with the gold standard of endometriosis excision to get to the root cause. But there's no pressure. If you don't feel ready for that, that is okay. I just want you to know all of your options so you can decide, what next steps are. So we only have a limited number of consultation spots each month. Once these spots are filled, we pause booking so that we can actually care for the women that are already in our system. If you're watching this right now, that means we still have a few openings. Cyrus, my office manager, has the ability to use some of these openings, but they don't last. They do go fast. So again, there in the chat is a calendar link where you can meet with Cyrus and talk to her about getting a visit scheduled with me. It is not a direct visit with me, just to clarify. But I look forward to meeting you and getting to know you and really doing a deep dive into your, symptoms and giving you the quality treatment that you deserve. Women's health care, again, is devalued, but it is very important. Endometriosis is not rare. It is a condition that affects 1 in 10 women, and it's the most common cause of unexplained infertility. And it affects women at really young ages, missing school, missing work, and frequently gets mislabeled. And so it is very important to trust your instincts and advocate for yourself. Ask those good questions, start to connect the dots, and understand that there may be one underlying etiology that is causing all these, multi-system symptoms that you're experiencing. So imagine what it would feel like to finally stop second guessing yourself, to understand what your body is doing and why, to walk into your next appointment informed instead of anxious. You deserve more than it's just stress. You deserve answers. And so I would love to be able to meet with you and talk to you about some of your options. So click the link, to schedule a time to meet with Cyrus and then ultimately get on my schedule. And we'll get you out of this dismissal loop for good. We want to make sure that you're being heard and that we find a treatment plan for you because you deserve it. Again, endometriosis steals a lot from patients, a lot from families. But if we treat it, the earlier, the better. And by having high quality and evidence-based treatment plans that is multifactorial, that's when we're going to get our best outcomes. All right, so a few more questions here. Do you do televisits or only in person? I do telehealth visits. My clinic is typically on Tuesdays and Wednesdays. But yes, office visits, both. I have an office in Plano and an office in Dallas. Actually, starting in March, we will have only a Dallas location, but it'll be our permanent location. But we do telehealth visits, and quite frequently, probably half of my visits are telehealth visits at this point. And let's see. This patient asked, why is it hard to find providers who perform excision surgeries rather than ablation? This is a complex answer. One is we're not trained to do it. In OB/GYN residency, most of our training is placed on obstetrics and pregnancy, which is very important, but we don't get very thorough surgical training. And surgical excision is more difficult than ablation or burning the endo. I did an extra 2 years of training specifically in endometriosis fellowship to focus on excision. Um, Also, this is not the only reason, but insurances make it very difficult to perform excision because they don't reimburse women's health very well. And when you go in and do ablation, you get reimbursed the same as if somebody's doing excision. And as excision is technically harder, it takes a lot more time. And so it's also easier for doctors to go in and burn a few areas rather than to cut it out, because they get the same reimbursements. And that's not the only reason, but it's very complex. But ultimately, we're not taught about excision, and also it's difficult. Many doctors don't feel comfortable removing endometriosis from the rectum or the ureter or the bladder. And so you have to have a skill set to be able to feel confident to remove all the disease. Because if your only tool is to burn it, you have a very high likelihood that we'll have to leave disease behind. Um, Anyways, I have loved getting to talk with you guys for this last hour. I hope that you learned a little bit about endometriosis. I hope you learned a little bit about how to advocate for yourself, how to connect the dots, understand that negative imaging does not equal no disease or no diagnosis. Understand some of the better questions to ask to be able to find answers and kind of understand how this disease is, the sequela of this disease can affect many different organ systems. I would love to meet with you one-on-one to go through your symptoms individually and create a plan so that you can see some benefit. I mean, we are early in 2026. I think this is a great time to focus on our health, and next steps. So use the calendar link, like I said, in the chat to schedule a visit with Cyrus, my office manager. So remember, this link is not a visit with me directly, but a visit with Cyrus so that she can get you scheduled, and on my clinic schedule down the road. But I appreciate you hanging out with me for the last hour and learning a little bit more about endometriosis. I will have a webinar about every month. So please just use the link. I would love to get to know you and keep advocating for yourself. And I hope you guys have a good start to your 2026. Bye-bye.